Hi, good evening, guys. I'm Dr. Ryan Bonwani, one of the chairs for the Young Innovators at ASPN.
And my name is Nasser Khatri, another one of the co-chairs of Aspen Young Innovators.
So we're going to give it about 30 seconds or so for other people to log on in, and then we're going to get started with our great content tonight.
Thank you to everyone who took time out of their evening today to really join us for what I think is going to be a really informative, educational webinar talking about remote monitoring and really the advancements in spinal cord stimulation. As we all know, we've seen a dramatic increase with regards to the innovation in the field of neuromodulation, spinal cord stimulation. And I think that really our next hour and a half of what we're going to be talking about here is going to be really kind of showing what the future of this field really holds. Dr. Badwani, what are your thoughts?
The goal has been always to innovate with the main central vision to better improve the care for our patients. That's really the core mission of Aspen. And as you guys will see in the next couple of weeks when we hold our 6th annual meeting, it's really going to be the collaboration of that spirit. So that being said, this technology in our space has continued to evolve. And as the evolution of wearable technology, this is really another form of that in the spirit of spinal cord stimulation. And that's kind of why, we're really incredibly blessed to have this amazing leadership on tonight to share with you really the next step in advancing care for our patients. Now, I know we have a lot of information here to present. And so typically, we would do a panelist type of a discussion, but I don't think we're going to have time for that just to make sure that we cover everything. And so what we're thinking is that we're going to have each presenter present one after another. And then at the end, we're just going to have some closing remarks and kind of go from there. And then hopefully we'll see everybody in a couple weeks in Miami for this great meeting.
I will go ahead and introduce our very first panelist or guest here today, Dr. Chris Gilligan, who is going to be a wealth of knowledge and really talk to us a lot about patient journey transformed and this remote patient management as well. Dr. Gilligan, we're super excited to hear everything that you have to teach us about this.
Well, Nasir, Ryan, thanks so much. And then thanks to the organizers for letting me participate. So really, really glad to be here with you. So let's start out by talking about the patient journey transformed. So 60 years of history with Biotronic, really a leader in pacemakers and cardiac rhythm monitoring. They're sold in 100+ countries. Millions of devices have been implanted worldwide. 250,000 messages are transmitted daily from their patient devices. And they have had 0 Class 1 recalls in the last 20 years. And I had the privilege of touring their manufacturing plant and headquarters in Berlin. And seeing that, it was very clear why that's the case, what their commitment to quality is. Advances in SCS have created a new generation of products. That's phenomenal, and randomized controlled trials have shown exceptional results in terms of pain relief with the latest technology. And you can see here the Sunburst, Whisper, Evoke, DTM, and Senza trials, all showing exceptional results. But the problem is that the focus in our industry, up to in our sector, has been on getting to implant, getting the patient identified, getting the patient consented, a trial results, prior authorization, consent for an implant done. But that's really previously been the end. As now the patient's implanted, they can call the rep, they can follow up with us a bit, but the focus was on getting to the implant. So the complication rate overall with SCS, I think we would all agree, is frankly too high, a 35% complication rate from the literature, and an overall explant rate of 24%. So for the complications, 65% of complications occur within the first 12 months post-implant. And for the explants, 72% of explants occur within the first 24 months post-implant, and 19.6 months is the median time to explant for loss of therapeutic effect. But that doesn't even account for the virtual explants, so the silent explants, when the patients turn off their SCS device without having it surgically removed. So why do patients get explanted? Well, this is also from the literature, and you can see 76% of the patients reported more than one patient burden. And you can see the patient reported reasons for discontinuation of SCS. Why did I stop using it? Uncomfortable stimulation, maintaining my device, scheduling time with the rep, or the healthcare provider rather, attending appointments, accessing the rep, recharging, etc. But again, 3/4 of the patients had more than one of these burdens. So when issues occur, the intervention to optimize therapy is a challenge with in-person care, right? We all know it. You call my office, does somebody call you back? When can they get in? Can we reach the rep, etc. All of this is an issue for the patient, for transportation, losing motivation over time. For the caregiver, they don't have ability. There can be financial burden. For the industry, long wait times and inability to connect with the rep, and for the clinic, getting in to see all of us when we're so busy. And all of those are obstacles to optimal care. The Prospera system, the idea is how can we give an optimal SCS experience daily and over the whole lifetime of the therapy? So up through implant, but also post-implant. And resonance is their multi-phase stimulation paradigm. Proactive care is daily automatic objective remote monitoring. And again, the keys there are daily automatic and objective remote monitoring and remote programming. And then 1.5 and 3T full body scans with no exclusion zones. So now let's dive in a little bit more on this topic of remote patient management. For heart failure, we've had pacemakers and ICDs, remote monitoring that triggers medication adjustments and regular diagnostics. For diabetes, of course, we've had daily blood tests and even continuous glucose monitoring, medication adjustments, regular diagnostics, and then COPD. Breath and pulse ox treatment adjustments and regular diagnostics. Now Biotronik is entering chronic pain, but my point is, with this long history, this tremendous experience in those multiple other clinical areas, it's not they're bringing all of that expertise from cardiac monitoring, diabetes monitoring, and bringing all of that expertise in remote monitoring to our field. So remote monitoring defined. Expanding the patient care through remote therapeutic monitoring. The point here is remote therapeutic monitoring refers to the use of medical devices to monitor a patient's health or response to treatment using non-physiologic data to manage a treatment plan. That's a diagnosis from CMS. CMS has payment codes for it, a clear definition. This is not something that's been invented by Biotronik or any other company. Rather, it's a clearly defined category that this fits into. Advance the slide, just one for the bullet there, please. So RTM can be used to monitor treatment specific to pain, functional status, therapy adherence, and response to therapy. And again, it's a well-established definition from CMS with well-established reimbursement to go with it. What are the benefits for monitoring and cardiac rhythm monitoring, where Biotronik has just been a leader for decades? Well, it reduces office follow-up burden and provides earlier detection of arrhythmias. It reduces hospitalizations for atrial arrhythmias and related stroke, reduces inappropriate shocks and extends battery longevity, and then finally just reduces all-cause mortality. So again, Biotronik has decades of experience with countless patients using remote monitoring in ways that have literature-supported profound benefits, and has brought that to our field. In terms of the cardiac rhythm management, you can see back in 2008, the first society consensus statement on best practices, and then spinal cord stimulation, 2023. I was honored to be able to participate with many of the speakers this evening in writing the first consensus publication on remote monitoring for spinal cord stimulation and the opportunity to transform patient care through the adoption of remote device management. And I think Tim Deere is going to speak to us a little bit more about that consensus. This is looking on the top at just the history of spinal cord stimulation from 1967, the tonic stimulation paradigm, 81, the FDA approval, 2015, HF10, 2016, burst DR, et cetera. And then below you can see that Biotronik has launched research in this area in 2010. And then the Biotronik did the different studies, Benefit in 2017, Benefit 218, Modeling 2019, Benefit 3 2021, and Prosperity 2023 got FDA approval. What are the elements of this? The key is automatic daily objective data capture to support proactive SCS patient management post-implant. So what are the elements that allow that make that possible? Well, the objective data capture provides consistent and reliable information. There's nothing subjective. There's automatic transmission of the therapy and device data. The patient, no one has to do anything, it's just automatic. And it's daily transmission so that the patient therapy stays optimized. If there's an issue or a potential issue, the alert for that, it's daily, so we can get that information and respond to that information in a short time loop before the patient goes down a bad path, loses hope, gets disengaged, etc. What's the implementation process? Well, the device actively transmits the therapy and device-related information. It's passive data collection without any manual input from the patients, the providers, the reps. And like I said, because it's automatic and daily, there's rapid intervention by the Embrace OneCare team that allows for proactive therapy adjustments and education. And again, this move from the era of focusing on the implant, and then once it's implanted, we're done, to focusing on the continuum of care and making sure that even after the implant, the patient continues to do extremely well. Thank you so much.
Thanks so much, Chris. Good evening, everybody. My name is Ramo Naidu, and we're going to define what proactive care is. So for all you fellows and young innovators and physicians out there, what we were taught in fellowship was we really need to set out the goals for the therapies that we use. And one of the expectations we have with spinal cord stimulation especially is for our patients to reduce their medication use, whether that's opioids or even neuropathic pain medications, which have their own side effects, or even NSAIDs, to improve their quality of life, to increase their function and their activities. And we expect them to be able to manage this very complex implantable device. Our patients are not neuromodulation experts. As you can imagine, many of our patients may not even know how to use their cell phone appropriately. And here we are implanting these therapies thinking, all right, hands done, incision closed, good luck, you're going to be great. And that's just not the case. There's some maintenance that has to happen with these devices. And so what this platform with Biotronic is trying to do is really take that out of the patient's hands. So I'm going to go through what the standard of care is. No matter which company you're using right now, if you've implanted prior to last year a non-Biotronic system, you're operating like a car in the 1930s or 40s, where, if you think about today's cars, whether you're driving a gas or electric vehicle, the pressure of your tires, your oil is low, check engine lights, you've got all these alerts. And our spinal cord stimulators right now don't have any alerts. Our only alert is a patient saying, something's not going right here, I have pain. And then that necessitates this whole cascade of events. So let's say you have your patient who has our traditional spinal cord stimulators in the market today. Maybe you implanted them a month ago with a non-Biotronic product. If they have an issue, your device turns off accidentally, they turn the stim down, or they just notice, they're losing relief from their device. What do? The pain returns. From the Biotronic data, we know that takes about 11.5 hours. And so then they call the rep or the physician's office or the APP. And of course, that may not be instant. It may take some time. And by the time they actually get a hold of somebody, it may take, on average, from the Kantar data that has been presented, it takes 7 days. That's great. Patient gets reprogrammed, next click, and the patient's happy. Their pain relief is restored, yay. But how much time has gone by? 9 to 16 days. And that's a really long time. That's an amount of time where you have a grandmother or a mother or a sister who's suffering in pain, who's not getting relief and therefore not having belief in the therapy. And if that happens more than once, which it can, that can really result in patients not wanting to use their devices. And that's what we call a virtual explant, where patients basically give up wanting to make this device work. They just keep it off or don't really use it. And they never tell the provider that, hey, this isn't working. So it's just in their body without any utilization of therapy. And that's, again, problematic for our space. So we have to understand our patients are not neuromodulation experts. We need to expect and rely on our stimulators, our devices, to alert us of any device-related issues. And that might seem so basic, but it's huge because, again, if you're not using this platform, that is the standard of care right now. And really simple things can lead to unintended consequences. So as I said, the device may be turned off. And some of you might be laughing, like, how could a patient not know that the device is off? In my 12 years, I've seen it. And I'll give you some examples. We've seen patients use the wrong program. We've seen patients not understand how to charge appropriately. Maybe they're charging too frequently or too infrequently. They forget the paddle or the recharging paddle cables when they're traveling. So lots of issues come up, including subtherapeutic amplitude. So how do we figure that out? How do we know if these things are happening? So with the Prospera IPG platform by Biotronic, we've chosen certain triggers to take effect. And as Chris mentioned, every single day of the week. So we have automatic daily transmission for these particular triggers that we've chosen. And Tim's going to go into the ones we've chosen as an expert consensus panel. And we think these are foundational. So low device usage, again, getting back to the on-off. Therapeutic window, this gives you an idea of the patient's therapy compliance. Are they using the device for its intended needs or not? Then you get an idea of charging compliance. You can actually see a capacitance graph over time, from 100% down to 10%, recharge back up. You get a sense of their behavior. How frequently are they recharging? Are they recharging too infrequently? Or maybe they're OCD and they recharge every day, which isn't necessarily a bad thing, but of course affects the longevity of the IPG capacity. And then active electrode out of range, which I think is super important during the trials, during the implant surgery, and then of course long-term. So years later, when the integrity leads may break down, one of the foreshadowing signs is seeing these electrodes out of range, which we've seen with other systems. But now being able to pick that up early gives us an opportunity to repair that lead prior to it failing. And again, therefore, you're leaving the patient without that loss of relief. So this is how it works. Again, I think this is a moat that Biotronic has created against the competition, which will take at least a couple years for anyone else to get to, and that is this. So these IPGs, the Prospera IPGs, get their diagnostics, all the data we're talking about here, the device, the program, charge with capacitance, etc. And then that is transmitted to their Samsung smartphone device. And you might be thinking, well, why not have their own app? Well, other companies have done that, and there have been problems with it. So this device is specific to Biotronic, and then every night, the app uploads that information to the cloud, run by Salesforce, and then a data form sheet goes to a remote care team called the Embrace One Care Team, and they're able to review the data on a daily basis. And so they can basically go through their dashboard of what is compliant and what is not compliant, and then feed that back to the patient. And this is a wonderful thing, right? So they can call the patient, educate them on, hey, Mr. Jones, we've noticed that your battery's down to 8%. A little worried about it getting too low. Maybe consider recharging. We notice that you don't charge very often. We recommend, based on your power consumption, recharging every week. And that could be a 5-minute conversation that really changes the trajectory of how that patient interacts with the device. The most important thing about this diagram here is, guess who's not in it? I'm not in it. The provider's not in it. And this is huge. I mean, if you're currently running your practices right now, you will get those phone calls in the middle of the day, whether it's through your EMR or the phone call or whatever else. Hey, someone's simulator's not working. And then what do you do? You have an algorithm. All right, well, bring them in, impedance check, x-rays, and it takes time. It's not bad or wrong for us to do that, but it takes up time and it takes up our mind share from other patients that we're trying to see. And so having this all happen in the background gives me peace of mind, knowing that patients' devices are working well. There's a whole remote care team who's going to make sure that the therapy is working well. And if I get a call, I know it's the real deal. Like, I know that all of the simple checks have been done, and that probably now it is something where a physician really does need to get involved, not something as simple as, oh, it turned off and they just forgot to turn it back on. So I think this is a really important thing for all of us. So that Embrace One Care team, it provides timely education, as I just mentioned. They're able to remotely program patients anytime and anywhere in the world over LTE or cell phone networks or Wi-Fi. And I'll, before handing off, give you an example. Last year, I implanted a patient, 76-year-old woman, horrible osteoporosis, vertebral compression fractures. She had about 6 or 7. 1 or 2 of them actually had retropulsion, resulting in lumbar spinal stenosis. She had neurogenic claudication. But because of her severe osteoporosis, no surgeon wanted to touch her. And I was not interested in doing an interspinous device. And even though we had tried the mild procedure, it didn't work well enough for her. So we ended up doing a spinal cord stimulator for her, implanting her. She got 75% relief, was doing really well. One of the interesting things about her, though, is that she's Italian. and she spends 3 to 4 months of her year every summer in Italy. And it turned out, I heard this after the fact, she had inadvertently changed her program while she was in her house in Lake Como, while showing a friend her device, and it was not the appropriate program for her. And the Embrace One Care team actually picked up on that, gave her a call and said, hey, Miss So-and-so, we noticed that you're not using the right program. And she said, oh, my goodness, you figured that out? Oh, I was just showing a friend of mine this device and maybe I accidentally changed it. And they said, no problem, we'll take care of it. We're able to remotely change it back to your program. And they did that. And so that to me was mind blowing because I have a number of patients who live internationally, and 5 years ago, or even 2 years ago, someone moved to Paris or moved to London. I had to find the physician there. I had to find a rep there through industry to figure out how is this patient going to be managed when they're abroad. Now, I can still manage these patients even if they are living abroad, and I think that's another value add with this platform. So with that, I'll turn it over to Tim to go over the consensus panel. Thank you so much.
Well, it's a great honor to follow Ramo and Chris Gilligan. And I want to thank Ryan and Nasser for the great work they've done on this broadcast. Many people will see this tonight. Many people will see it over the next month or two online, probably a lot more at that point. But I've been asked to talk about our consensus. So when we start anything new in our field, we have to determine the best uses of it. And we do that based on evidence-based medicine, but sometimes when things first start, there isn't a lot of evidence there. So we have to build the evidence. In the meantime, we use a consensus of opinion. And how does that apply to neuromodulation? And particularly here with remote monitoring. So I have a triage nurse named Janet. And so if you call my practice with a problem, Janet will call you back the same day always. She does a great job. But then she has to find the physician or the nurse practitioner or someone in the practice, alert them. And then we have to find the other person who might be on call if someone else is there. So it becomes very complicated. It may take a few days to really resolve an issue. So can we have a consensus how we can do a better job with remote monitoring? And so that's what we're going to talk about for the next 7 or 8 minutes or so. So, what is the consensus? I've done these for years. I started doing consensuses back in 1999 when I worked with some colleagues of mine to create the first PAC or Pump Consensus Conference. And it's a collective judgment or position of a community of scientists in a particular field of study. And you take evidence that's available and you add expert opinion. And that consensus builds, and as more evidence comes along, the importance of the consensus goes down. So early in the advent of something, the consensus is even more important because it's really that expert opinion of how to use something that leads research in the future. It generally applies a supermajority and doesn't have to be unanimous, so we can have dissent. And if you read a consensus paper, we just published 2 new NAC papers, neuromodulation consensuses, you find there's a few people who disagree. And sometimes a disagreement leads to new hypotheses. So that's what it looks like. Is this new? Is this something we thought of? No, that's not new at all. Back in 1142 AD, there was a group of Native Americans who disagreed a lot. Much like you may find if you go to the ASPN meeting July 11th to the 15th, you may find disagreement. And they said, well, how can we not fight and cause war? And I think we're tribal in neuromodulation as well. We have companies we like to use. We have friends we like to listen to, KOLs we respect. But how can we make a consensus to get the best thing for all of us? So the Iroquois, you may also know the Iroquois from, the game of lacrosse, because they actually were the inventors of lacrosse. They used to fight to the death with that sport. And what they did, they got some other Native American tribes, and they determined, where should we hunt? How should we hunt? What do we do with buffalo hides? Not the same thing as remote monitoring, but that led to a lot of agreement and really led to them all doing well and thriving. And that's our goal with the consensus conference. And that wasn't just really the Native Americans. The Quakers then came along and they thought they had to be unanimous because it was divine will. We don't have to be unanimous with our consensus, but this is how it was in those times, which led to the 1600s. And then there was a group of traders in Germany, in the Germanic tribes, and they had to agree how to be at peace as they traded the goods throughout European ports. So, I mean, again, we think we're always doing something new. The consensus really is as old as really the Iroquois. But in modern times, consensus began with Sam Hassan-Bush and Michael Cousins, who in 1999 got us all to the Plaza Hotel, New York, and said we need a consensus on pumps because we don't have enough data to make an evidence-based decision. That led to a group of consensus. We've led a lot of those over the years, and I want to talk about our most recent consensus, which is the consensus on remote monitoring. And Dr. Gilligan and Dr. Nadu brought some of this up. Let's get into this in just a little bit more detail. So we actually got together at ASPN 2 years ago, and we decided that we needed a 2023 expert opinion on how we should remotely manage patients, how we should remotely monitor patients, and the response, what that should be, and how, if we have reimbursement for that, what should guide that. This wasn't anything new either, because this was led by Peter Statz and myself and a lot of our colleagues you see here, but it really wasn't new because in the cardiac space, they had been doing remote monitoring for many years, and Biotronic had been the leader in that space. Let's look at what we recommended based on that evidence-based medicine from the cardiac world and opinion from the neuromodulation world. And so what we found was remote monitoring, the ideal thing is a continuous remote monitoring of the patient in a passive way. So automatically, daily, there's remote monitoring, and that's done passively. And I think all device companies hopefully will get to this down the road. I think this will be the optimal spot. Then at periodic periods, we recommended the healthcare professional. And it doesn't have to be the physician. It can certainly be the nurse practitioner, the PA. But there are certain critical points that they identify to assess a chronic medical condition or any acute event. And then if they aren't really recognizing that a long time, there may be some parameters we set where there's a notification needed, where someone falls out of therapy, for example. The device quits working. There's a high impedance. That then they notify the identified healthcare provider that, hey, by the way, remote monitoring has shown an event that requires notification. This would lead to improved patient safety and also particularly identifying a failure of therapy very early. So as we build that, we thought, well, how often should you monitor this? So we recommended the metrics for a typical SCS patient who's stable after 1 year. It may be more frequently early on. So weekly or monthly, we want to look at their activity level. We want to look at really their pain intensity score. And is there anything going on with the device, impedance changes? Is there anything going on with patient-reported outcomes that suddenly worsen? Those are things we'd want to see pretty frequently. What's a battery state of charge? If someone doesn't understand how to charge their battery, for example, we could see that because the battery charge goes away. How much do they use the device, and are there high impedances which may look like a fracture, for example, of a lead? Less frequently, we look at the program parameters. We may want to look at that once a year. Is there any duration changes of how much stimulation they use, things of that nature, and really look at the quality of life surveys and things like that to really look at outcomes, not just for this patient, but we can do big data based on this, which I think is very important. Big data will become more important to you than you ever imagined, because it's going to change the field, because we can identify what does work and what doesn't work. So these are things that would be less frequent, but maybe every quarter. And quarterly might be 4 times a year, very reasonable. So we think about that. What are our roles and responsibilities? Well, as physicians or nurse practitioners, PAs, we have to design a workflow that we can do in our office. For example, if you had to do this all the time, you may not have time. So what provider may have the time to monitor these things, particularly if there's a reimbursable code? What's the best use of our time to make sure we do that? What are the goals of monitoring? Are we trying to find people who are falling out of therapy, optimize therapy? What's the cybersecurity? We have the same HIPAA requirements we have on every patient chart. We want to have informed consent for the patient to make sure they want to be involved with this. For the patient themselves, we want them to set goals so we can monitor those goals, engage the therapy, and really look to maintain contact with the patient. And then for the industry, I think industry has a big responsibility for confidentiality, but also they're there for data collection, data consensus, and really analysis of data, and provide support to us and educate us on how the patients are doing, and identify a risk for the patient, but also for the therapy and globally. So I think it's a collaboration of the patient, the physician or care team, and the industry. So this leads to reimbursement. And in the heart world, there's been reimbursement for these types of activities. So you have to have time, effort, and resources spent for remote care. that's a work value unit, or RVU, relative value unit, for the physician or care team, and it has to meet certain coding criteria. If you read our article published in Neuromodulation in 23, you'll find very specific recommendations to assure you may meet the coding requirements to be compliant. You can see them in this slide. We're doing remote physiological coding, remote therapeutic monitoring codes, and under those categories, you have different things you want to meet. And I think that's very important how you review those. And then that leads to really the requirements we're looking for. And it's important because as we look at reimbursement, we want to make sure we're compliant with all federal and national guidelines for reimbursement, but also that there's medical necessity. There was a reason to do this. I think we've shown that to you already tonight. Now we have another 45 minutes or so to go. We've shown you there is a reason, and that reason is medically necessary and compliant. Those are important things here in reimbursement considerations. So future considerations, I think this may be my last slide. We're giving it that consensus was in 2023. And many of you who know me know I often repeat consensuses a few years later. I think there's going to be a need in 2025 or 26 to repeat this, because this field's going to evolve. As it evolves, we're going to see new technological advances, artificial intelligence. We have new clinical evidence out there that we need, and that will change really the standard of practice, advancing the capabilities of each device in our clinical judgment. So that will lead to device management. Talking about remote monitoring, but there's also remote device management, and that will lead to really real-time care. So we can see someone, and Ramo mentioned someone who went to Paris. I saw a patient today who came to visit me, who lived in North Carolina to West Virginia. They can go back to North Carolina, and hopefully I can notice a problem, go in and remotely program that patient and change their outcome. That's a long-term goal, that we can make this easier and more efficient for the patient, improve the quality of life, improve the outcome. So to summarize, our consensus is that we really need to use remote monitoring to identify problems, and then eventually use remote SCS management to correct those problems. And that whole that whole assembly of things involving multiple people, we lead to a better outcome, and we lead to reimbursement for the work done by the physicians and the healthcare team in the process. So with that, I'll give you to my good friend, Dr. Kazra Elmodelfon. Thank you very much. I hope to see many of you in Miami, July the 11th to 14th at the Fontainebleau. Kazra?
Hi, Tim. Thank you so much. That was fantastic. Good evening, everyone. Thank you all so much for joining us. This is a really exciting time with the ASPN annual meeting coming up, and this new platform that is really changing the game in spinal cord stimulation. We've seen a lot of new paradigms come into play with spinal cord stimulation over the past decade. And with every new paradigm, we've seen improvement in the patient care, we've seen improvement in their pain control, and longer term effect of therapy for them. But the big question is, how can we increase the compliance for the patients? How can we use remote care management and remote device monitoring for us to be able to not only make it a lot easier for the patients to stay compliant, but also catch things early enough for us to be able to treat it. But in order for us to understand it and do it well, we needed to study it. So the Australian physicians, the likes of Dr. Russo and Dr. Barrows, are actually conducting a study for us called the Benefit 3, which actually uses the Prospero system and multi-phase stimulation, which we call resonance therapy, with automatic objective daily device monitoring and remote programming to optimize the proactive care for these patients. These patients are no different than other SCS candidates. They come to the doctor's offices. They're deemed to be good candidates for spinal cord stimulation. They enroll in the study. They go through a trial. And if they have 50% or more pain relief, which is exactly the standard of care for spinal cord stimulation, they're offered a permanent implant. If they're implanted with the Prospero system permanently, then they go into the study itself. The patients have a wound check, and they have in-office visits at 3, 6, 12, and 24 months, but they have proactive remote checks monthly for the first 6 months of the study. Beyond that, between 6 to 24 months, because this is a 2-year study, the patients are checked on remotely at least every quarter in order to ensure that they're compliant with the device use and their pain control is as optimized as it possibly be. Aside from that, the patients had an app where they could actually provide the investigators and the company with daily pain and daily sleep scales as well. So the responder rates are typically defined as 50% or more pain relief. For back, leg, and overall pain, for the patients in this study who had gotten to the 12-month mark, the responder rate for back pain was about 76%. The responder rate for leg pain was an impressive 89%. And for overall pain, that responder rate was 82%. Aside from that, with the newer paradigms, we're seeing more profound and better pain relief. So we are now looking at a high responder rate as the new standard for a lot of these new spinal cord stimulation paradigms. And the high responder rate is defined as 80% or more pain relief. For back pain, about 50% of the patients had 80% or more pain relief, 78%. And for overall pain, about 60% of the patients had 80% or more pain relief in this study so far. Now, if you don't learn anything else from me, remember these four proactive care triggers that Biotronic has designated as their standard, where they can actually intervene and help the patients in order to be able to optimize the therapy. Low device usage, charge compliance, the therapeutic window. If the patients are out of the therapeutic window, then obviously they're not getting optimized therapy. And last but not least is impedance out of range. That means if a contact is not where it's supposed to be, or say there's a fracture in the lead. The transmission rate was a very impressive 92% for the patients so far. And the reason 92% is impressive is mainly because of the fact that this is not a first generation device for Biotronic. It is a first generation spinal cord stimulator device, but Biotronic has been doing remote care on the cardiac side for decades. They perfected it. This is the reason the transmission rate remains so high. There was 83% of the patients activated at least one trigger. Another testament to the quality of the product itself, there's been zero impedance triggers. So all the contacts that have been functioning have continued to function at an optimal level. In order for the company to understand what the issue was before we started to undertake remote care and remote monitoring and remote programming in these patients, they needed to understand what the burden was in the real world. So they did a study called the Cantor study. Please direct your attention to the lower part of this chart. In the Cantor study, with real world spinal cord stimulator patients who did not have remote care and remote device management, from the time that they actually raised the issue to the time that the issue was addressed, the average time that it took was about 7.2 days. In the study itself, the time went from the time that the proactive care trigger was activated to the time that the issue was addressed, it was 2.2 days. So 5 days less. Faster is always better with pain patients because we want to try to address the issue as fast as possible to keep them compliant with their therapy and make sure that their therapy is optimized. But keep in mind, these patients are in Australia and the remote care team happens to be in the United States. So there's obviously a time difference and the remote care team works from 8 to 5. So that time lag actually was added to this 2.2 days. So theoretically speaking, if all these patients were in the United States and the remote care team was in the United States, this time period should be shortened quite a bit. And the real world data will be a testament to that. In fact, the early data from the first few hundred implants is now available, and it's going to be presented at the Biotronic sponsored lunch symposium at the annual meeting at ASPN in a few weeks. If you haven't registered for that meeting, if you haven't made your trip plans yet, this is the time to do it, and you'll get to see that data at that lunch symposium. This is basically the satisfaction rate of the patients with remote care. And they thought that the follow-up was very easy. They felt very comfortable using remote care management. They would choose this NSCS device with remote care management capabilities once again. They thought that the remote care gave them a lot more time for them to be able to increase their activity of daily living. And the majority actually thought that it reduced the cost of traveling back and forth to the doctor's office. And 100% of the patients preferred remote device management versus in-clinic follow-up. And that's, I'm not really surprised, and I'm sure you're not either. Aside from that, the clinicians were also impressed with the clinicians reporting that the patients actually did respond to remote care. It optimized care for the patients much more quickly, and it was very good for the chronic care management of the patients. Aside from that, the burden on the office staff was reduced quite a bit as well. The 12-month follow-up for these patients So far, we have about 22 patients who've gotten to the 12-month follow-up, but we should have about 50 patients, and that 12-month data should become available later this year, and hopefully maybe by NANS, we'll get to see that data. But aside from that, we want to see the real-world data, and that's really important. So in conclusion, automatic daily remote monitoring allowed for rapid, proactive identification of the issues and help the patients optimize their SCS therapy as soon as possible, 5 days less than what the real-world data had shown us so far. Nearly all the participants preferred remote SCS adjustments due to the cost savings and the increased amount of time they had for them to be able to enjoy their lives. And last but not least, the physicians also preferred remote care management because they felt that not only the patients benefited from it, but the office staff had a lot less burden dealing with the SCS patients who needed care from the company representatives. Thank you all so much for joining us. I'm going to turn the podium over to Caitlin. Caitlin Tourget is going to talk to us about the practice integration of a remote care management system with spinal cord stimulation. Caitlin?
Thank you, Kaz. Good evening, everybody, and thank you for having me. This is a really exciting topic. It's near and dear to my heart because it's really changed how I manage my practice, especially over this last year with these implanted patients from last April. So kind of the overarching themes, I think that before Biotronic came to market with the Prospera platform, there was a bit of a disorganized process, especially I think in private practice where resources can be a little bit more limited and you're trying to really optimize utilization of what resources you do have. And so I've been really pleased with the Prospera platform, the physician portal, and then also the long-term monitoring that Biotronics offered. So we'll just kind of briefly discuss what it looks like to operationalize this in your practice. So what I've done in my practice and what it's kind of looked like for me is starting very early in the education phase with my patients. So when we're starting to have these discussions, which tends to be on the earlier side just to introduce this therapy to patients, we also start by adding them to the patient portal. This allows us to go beyond just the MD or APP education that we do in the clinic and also involve the local reps so that they can start meeting the patients, they can perform additional education surrounding the device, its use, different questions that they might think of later after they leave my office. And so it really kind of enables a more thorough, well-rounded education for the patients. And what I found with that is patients are really pleased with, of course, the discussion with the physician is useful, but they head home and they think about things and they want to ask specific device-related questions. They want to know who they're going to be in contact with and what this looks like long-term. And so by getting them in the portal early, you're enabling the Biotronic team locally to start working on those things, and that frees up a lot of resources for you for additional visits of those patients coming back and asking questions that could have been answered in the interim. And it also just improves the patient experience. So then we kind of move through to the workup phase. For me, I'm doing additional imaging, including thoracic MRIs and things like that, which can all be logged in the portal as you move through those phases. And additionally, this is also the time that you're completing your psych evaluation. So it may be variable depending on where you practice, but I know for us, there can be quite a bottleneck with obtaining the psych evaluation, especially if there are small HMOs and things like this. So what I've really enjoyed about the Biotronic portal and their system is that we can use the portal to actually submit our psych evaluations and track them. So by going through the portal, they have a contract with this behavioral health company that is going to expedite these for you, complete them knowing the goals, they know the questions that are being asked, and they're going to get that done in a very expeditious fashion for you, and then that'll all be incorporated into the portal so that your insurance and scheduling folks all know when that's all been completed for you and can kind of move things along for you. Additionally, you can see in the portal the insurance approvals, the status updates surrounding have they been approved for their trial, are they approved for the implant, who's pending, and where everybody is in all of those different phases from education all the way to long-term monitoring. There's also the ability for the patients to enroll in the app. And so I like to early on collect the patient-reported outcomes in the app. That gives you a really excellent baseline for the patients even before the trial to kind of establish where they are before you start introducing these therapies. And then lastly, I kind of already mentioned in that workup, but you're able to get onto the portal and see every patient who is associated with you. So that lets you kind of establish what your timeline has looked like for these patients who come in and moving them through all these different phases of care to get them to the end game, which is the implanted stimulator and relief. So you can see, how long each phase is taking, who's living in which phase, and what the holdup is there to get them from point A to point B. For the trial, the way that this has kind of impacted what I do is you're able to create this pain map early, and then based on that, you're considering different lead placements and how that may vary from patient to patient based on pain pattern and pain region. Another thing that I thought was really interesting is you can actually schedule the cases with your biotronic team. So this is something I've been working on implementing in my own practice, but instead of your team, for example, texting your local reps and saying, okay, you have a trial at this date and time, it's actually going to auto-populate to their calendar and then update as you update things. So not every trial goes exactly when you think it's going to go. Things might be rescheduled to a different day or different time. And so this really enables a streamlined approach for your team to communicate with your local team very easily. And so everybody's on the same page about timing. Another piece of this puzzle, which historically for us in private practice has been challenging, is how to keep all of the fluoroscopic images locally so that you can reference them. If you're in the office, you're in the surgery center, some of us go to different hospitals, and not all of that has been readily available historically. So I'm frequently referencing these images, which are now saved in my physician portal. So when I go from trial to implant, if there are any modifications to make based on patient-reported outcomes or pain patterns during the trial that weren't optimal, or if everything goes perfectly well, we're able to see all of those historic images. Again, this is helping us to manage our advanced procedure timeline. In private practice versus academia, there's some variability about who's able to kind of keep track of these patients, but for me in private practice, I've really found it's a lot more streamlined and efficient if I can pull this up, see where everybody's at, and kind of send messages where they need to go to help people get through. But you don't want people just sitting in one phase of care thinking that you're going to do something differently. They're waiting for you, you're waiting for them. So this really has let me kind of optimize efficiency in that way. Additionally, during your trial, you are collecting all of the remote monitoring data, and then you are able to perform remote reprogramming as well. So those are really nice things that patients are really appreciating during their trial. For the implant, again, you can reference all these images so you can compare, make changes as are necessary for your implant. You can review their pain map, and then you can also schedule, just like with the scheduling the cases for the trial, you can schedule their implant and their post-op visits within the Biotronic portal as well. We'll move into talking about some long-term monitoring. So for long-term monitoring, there are a lot of different aspects of things we've kind of mentioned this evening that are going to be monitored, and you'll be able to access all of this data through the physician portal. So it's not enough necessarily just to keep track of it all by monitoring it. There needs to be a place that you can actually access it and act on the information that's being gathered. So historically, this was something that was reportedly available to all of our device reps, but not available to us as physicians. And I just kind of found that to be inappropriate, given it's my patient to manage and I'm responsible for them. I always wanted the access to everything that was being collected so that I could be the most effective physician for my patients. And that's what this has enabled me to do. So what I can see is there's all kinds of data being collected, and that's kind of an ongoing mission to funnel down what's useful to folks and what needs to be visualized. But there's just this whole host of information surrounding how these folks are using their data or how they're using their therapy, what kind of programs they're using, what recent adjustments have been done, what the battery use looks like, how often they're needing to charge it, any issues with contacts or contacts out of range or impedance issues, things like that, ensuring all the data is being appropriately transmitted, and any recent imaging studies or anything like that. If they have MRIs, we're going to know about it. This has been an interesting integrated piece of the puzzle too, because with each patient, we can see exactly what goes on in terms of contact with their Embrace One care team or their local reps. So in the past, I think a lot of people thought no news was good news in these spinal cord stimulator patients that were out there. If we weren't hearing from them, then it must be because they're doing so well. I think in retrospect, we all really recognize that that's not the case, but likely a lot of people lost faith in their device and didn't really believe they could get relief from it because it was taking so long to make changes, and They just didn't buy in after they had kind of been left out in the cold for so long. And so now when I don't hear from somebody for a while, I kind of think about folks, and that may be uncommon, but I'm thinking about these patients and I'm going, I wonder what's going on with them. I just pull up the patient and I can see every call, every contact that's been made, if there were issues, how they were addressed, what the resolution is, and I can get involved where I'm needed. But I know that if there are things going on that affect those 4 triggers, or if there are other concerns, long before I find out about it, the Embrace Care team's already acted on it. In terms of charging habits, this is just another thing that's being monitored. So this allows you to kind of be informed about when you're telling new patients or trial patients what to expect in terms of charging. You can kind of get an idea of what's going on with your other patients. You can see they learn, actually, the Embrace Care team was telling me they like learn about how different patients tend to behave with their device. So I have a couple of patients that tend to like run it all the way down before they recharge it. I have some like fanatic rechargers, and so they kind of see what their patterns are and they intervene and contact the patients and educate them based on what they're doing to kind of optimize those behaviors. But you're able to see, you know, the device is on, the device is being charged appropriately, it's being charged to full. So complaints like, for example, I've had patients with other devices say, oh, it doesn't last very long. I charge it and then I have to charge it again the next day for an hour. And then for this device, we can go back and look and say, actually, it's because you're not charging fully. That's why you're having to charge so frequently. So you just need to charge for longer and then you'll have longer intervals. But before, we just didn't really even know. I'm just sorry that you have to charge so much, you know. Another piece of information you get here is just looking at all of the different programs that patients are using and then also when the device is actually off. So this is going to trigger alerts based on your preferences in the physician portal. You know, how often do you want to be notified if patients are switching between too many different programs? For example, if they're swapping, you know, every day, every other day to different programs, or, you know, increasing intensity or amplitude of stimulation very frequently, this raises cause for concern that the therapy is not being useful to them, and this would prompt the Embrace Care team to reach out to them. So long before you see them for their follow-up visit and they say, hey, you know, my device isn't working, someone reaches out to them and says, hey, is that why you're switching, you know, program to program or chasing your amplitude up? How can we optimize that? And it's handled long before it makes it to my door. So for long-term monitoring, the time to response is illustrated in the Kantar data conservatively was about 7 days. That's about industry standard. And I think that tracks with other implanted device vendors, because again, you're talking about reaching out to a physician who may be in the operating room that day or maybe non-clinical that day. And then the message has to get to them and it has to, you know, transfer from person to person to the rep to get the patient in, all these different things. Whereas now the goal for the Embrace Care team at launch was 48 hours. And in many cases, they're actually substantially lower than that. And so the goal for this year has actually been set even lower at 24 hours. So I'm excited to see how that continues to evolve. I think that may be my last one. I'll pass to Dr. Bodwani.
Hi, thanks, Caitlin. You know, all the panelists, you guys have done an amazing job really showing us the evolution of this technology and, you know, where it stands today. And so with this section, really what I wanted to talk about is where do we go from here? What does the future of integrating some of this information and really communicating it to our patients look like? And so this disclaimer is important because part of what I'm doing here is really advanced AI technology use in educating my patients and hopefully keeping track of what's happening beyond. And so in my current practice setting, this is kind of where we've evolved to. And so I kind of wanted to share this with our viewers today because it ties hand in hand with remote patient monitoring. That information is providing us critical, you know, second by second information on how the patient is using that technology. And now with the ability to use artificial intelligence, like Dr. Deere had mentioned, perhaps, you know, in the future, part of the consensus for change will be a paper that, you know, talks about what the standard of care is and how the standard of care involves the use of artificial intelligence, really, you know, physician likeness technology. So artificial intelligence in patient education. Now we're going to talk about briefly, you know, the consent process, the patient education experience, and then advanced patient engagement. So what is generative AI? Well, by definition, this is a type of technology in artificial intelligence that allows us to generate new content, specifically, you know, text, images, video, and beyond. And you kind of have heard about this, you know, throughout the media. Everybody's talking about, well, artificial intelligence, you know, and video, everything else. But in our practice, how can this be used? What can we do to actually help benefit the lives of our patients and hopefully keep them in the theme of their therapy, right? Sometimes we struggle because, again, how do you measure excellence? Well, what people are they compliant or not? So remote monitoring is going to help us do that. But I think generative AI and the use of moment-to-moment data is going to actually help solve some of these complex problems. So how can it be used? I think personalized interactive education is one part of the solution here. So what are we all trying to do here? We're trying to create a different SCS experience. We've seen, the evolution of technology. We've seen the evolution of spinal cord stimulation devices, waveforms and beyond. But the common theme here is, what does it do for our patients? What does it allow them to do in terms of long-term compliance and outcome, right? We're always providing consistent education. Well, that's a big part of it. Like Caitlin mentioned that, early on, you get the patient in, you educate them, you get them into the portal, but then now you're leaving it up to the reps to follow through. Sometimes, depending on the practice setting, you may not see this person as a return patient, but maybe your APP will. And so sometimes, care can end up getting delayed. And so that's why we need to talk about, well, what can we do to improve engagement? What can we do to improve the collection of data and hopefully to continue to provide our patients that comprehensive care? So generative AI in action. These videos you guys are seeing here, right, in our practice setting, again, these aren't endorsed or made by Biotronic, but it's the way that our practice is set up to communicate to our patients. Every time a patient comes into our office, some pre-selected and pre-curated videos are provided. But beyond that, what happens is that even before I step into the room, if we've determined that, hey, this patient may be a good candidate for device A or device B, we have pre-curated videos. Now you're like, well, is that a difficult process to create? How do you go from, selecting all this information, looking at all the things that the patient may potentially need, and then providing them pre-recorded content? How often have you had patients that come in and say, hey, doc, this is great, but I wish my spouse was here, or I really want to, talk to my primary care doctor about it, or someone else in the community, or I need more time to think about what's going to happen next. And so no longer, at least in our practice setting here, do we have that type of question come up, because we have these personalized videos that are generated using generative AI and artificial intelligence to help better engage the patient. So all these videos you see here, we have a library of 60 plus videos. These are just some of the type of videos that we're using, and they're all generated by AI. And so you see me talking in this setting, or you saw me talking in the disclosures earlier today, or even in the invite to the meeting. This was all done actually by my physician avatar. This is important. Now I know you guys are going to read the slide, but I want you to understand what this means for our practice, what this means for our space, and what it means for the physician voice in our space. Remote monitoring and AI engagement, like Dr. Deere said, is going to change the way we practice medicine. The standard of care is going to change, and future consensus papers are going to actually include that. So what remote monitoring is going to allow us to do, along with AI engagement, is to improve patient compliance, improve patient satisfaction, outcomes, experience, and hopefully autonomy. But the other thing we need to actually take into consideration is, what does this do to help actually us engage with that patient? Keep that in mind, okay? Because we feel like, we see the patient and then we're handing them off to A, B, C, and D. We talk about how, Dr. Naidu mentioned that, his patient was in Italy and, there was something off. So the incredible team at Biotronic reached out to them and said, hey, this is going on. Let's see, what's happening. And they helped to reactivate or change the waveform and get the patient back into therapy. But what if it was you as the physician, your avatar, reaching out to that patient? That would be very, very different, very, very engaging, and a different sort of paradigm. My patients expect that it is a physician talking to them. And yes, they go through multiple touch points in our practice, but at the same time, I think that consistency of care is very important. So I want you to watch this video, and then we'll kind of comment on it a little bit afterwards. Biotronic's proactive care system is designed to keep you connected to your Embrace One Care team at all times. Your Embrace One Care team will review your device data daily to ensure that you are getting maximum therapy benefit. If there are any issues, the Embrace One team can make adjustments to your implant anytime, anywhere. The proactive care system also keeps me up to date about your SCS system at all times. So this is just a brief view of what we're trying to do. Again, it's using the content provided by different systems out there, such as Biotronic, through every other type of injection or interventional modality we offer. But it's using your physician avatar. So that's actually not my voice. That's actually not my face. It's an AI-generated physician likeness modality that's been created. For our patient experience, this is disclosed to them. But the important thing here is that they're able to, in a way, engage with what we're trying to do. And I want you to think about what that means, because the next video is going to actually help explain that a little bit better. Today, we are going to collect some information about how you are using your Prospera spinal cord stimulation device. Click Get Started to begin our optimization assessment. Let's start with your pain relief. On a scale of 0 to 100, with 0 being no pain relief at all, and 100 meaning all of your pain is gone, what is your percentage pain relief? Can you select the areas where you are still having pain? And lastly, of your current programs, which is working best for your pain? And so again, that's just a sample of the different types of systems that we are offering our patients using generative AI. Now, what that means is that if we're able to combine this type of technology with remote monitoring, then point by point, we're able to actually not only take care of our patients, but also interact with them in a different way. These aren't just pre-recorded videos. In the near future, within the next 6 to 8 months, you're going to actually see that when a patient interacts with your avatar, that avatar actually interacts back and helps to actually answer the questions and then lead them to a potential outcome and to get you back to that engagement. So I think that's kind of important, and it's something to keep in mind in terms of the evolution of why that happens. The reason we kind of mention this here is because, again, Biotronic is ahead of a lot of other systems out there in terms of keeping track of point-to-point care for our patients. And again, these videos, this type of content we're using in-house is not directly related to remote monitoring, but it's an adjunct to those tools. And what we found is just in our internal use, is not only is it helping with compliance in terms of therapy, but hopefully it's also helping them actually feel that we're consistently involved in their care. And so typically this is the end of our webinar tonight. I wanted to invite you guys to really attend this upcoming incredible conference in a couple weeks in Miami from July 11th to the 14th. And hopefully we can engage with everybody, and learn about the next steps in better serving our patients. So for those who attended tonight, looking forward to see you guys in Miami. Thank you.